Clear. Thank you.
Thank
How are
you.
you? How are you, Ricard?
Well, quite busy again.
Yeah, you building up.
Yeah, I think we are follow you. We are follow.
I know. Well, I'm.
Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas en fait. C'est primordial parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire ?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision, of that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Hello, everyone. Welcome to this ESICM webinar on COVID-19 block or boost the immune response. I am Ricard Ferrer from the ICU in Hospital Vall d'Hebron, Barcelona, and also the chair of the C section in ESICM. You know that the epidemiology of COVID-19 is always changing. Some countries in Europe are again facing an increase in cases and some increase also in ICU admission. So it's very interesting again to discuss about COVID-19 and about immunomodulation in this condition. You know that always in severe infections we have infection and inflammation, and we are always discussing if the inflammatory compound of these severe infections may be modulated or not, and this is a hot topic especially in COVID-19. But generally, these immunomodulators are not doing the same in every patient. So is some heterogeneity in responding to these treatments, and it's key to understand the different phenotypes and which patients cannot respond or not respond, and how to enrich the sample in clinical trials and try to understand which patients are going to respond or not respond to these immunomodulators. In fact, we are saying in the title, block or boost the immune response, because we are going to discuss some treatments that are having different effects on the immune system, and we want to discuss about it. So for that, we have two excellent speakers, Professor Manu Shankar-Hari and Professor Mervyn. Both of them are going to have discussions of about 20 minutes, and we will allow a Q&A session at the end of 15 minutes. For that, it's very important that you send your questions using the different chats in ESICM TV or in Facebook or in YouTube. So then it's my pleasure to introduce Professor Manu Shankar-Hari. He is a consultant in intensive care in Guy's and St. Thomas Hospital in London. He is also a scientist of the National Institute for Health Research in the UK, and he has an extensive background in sepsis, RDS, and of course, COVID-19. He has been the national coordinator, national leader, principal investigators in many research projects, clinical trials, etc. in this topic. So he is an excellent speaker, maybe the best speaker in the world for the current status of the evidence of this topic, the immunoregulation in COVID-19 infections. So thank you, Manu, for accepting being with us today, and thank you for your talk.
Ricardo, thank you for that lovely and generous introduction. It's an honor to be here, and thanks ESICM for the opportunity to discuss the topic. Just a brief acknowledgement to my funder. I am funded through an NIHR Clinician Scientist Award. So whatever I'm going to talk about are my views, not necessarily of the NHS, the NIHR, or the Department of Health and Social Care. I don't have any financial conflicts of interest relevant to this talk, but I just want to point out that I'm an associate editor in ICM, which is an ESICM journal, and I coordinate the IL-6 prospective meta-analysis that Mervyn might discuss. Before I kind of go into the immunology of COVID-19, I want to highlight one important point, which is that COVID-19 is a systemic illness. So the immunological discussions we are focused on is one element of that big systemic disease. When you think about the immunology of COVID-19 and the systemic nature of the illness should not be forgotten, because quite a lot of the treatments are targeted to some of those abnormalities, such as the neurological abnormalities. There is greater prevalence of acute kidney injury in these patients. There is transaminitis, and as we are beginning to recognize, there is a gastrointestinal component to both the pathogenesis of disease, especially in probably in children and in the context of post-COVID condition. There is a greater risk of thromboprophylaxis and perhaps some differential treatment effect with anticoagulation. We all know and recognize the cardiac problems in these patients and endocrine abnormalities, in particular hyperglycemia during the acute illness and the diabetic complications post-COVID. So it's a complex condition, but it has got many similarities to what we as critical care doctors look after, like sepsis and ARDS. So we can't completely unlearn everything we know, but there are some differences which I'll try and highlight in this next 15 minutes. Before I kind of go into the discussion of immunology, one of the things that often come up in the immunology discussion is this early versus late disease. So if you were to think about the progression of COVID-19, there is a pre-symptomatic phase or an asymptomatic phase, which is very common. And that is where the virus replicates in the upper respiratory tract. And then once you start to get evidence of pneumonitis, that's when you start to feel the symptomatic phase of the disease. And we think that there is roughly a 7 to 10 day period between that symptomatic early disease to much more severe disease that requires multi-organ dysfunction and organ support. So when I talk about early versus late phase, I'm talking about somewhere between 7 to 10 days after symptom onset in the context of immunology. So let's kind of look at the basic pathobiology with that background. So the virus enters cells through the ACE2 receptors and the TMPR SSR2, and this interaction is the receptor binding domain of the spike protein. And like with any viral infections, it is potentially cytotoxic to the cell that it infects. And there is dysregulation of the renin-angiotensin-aldosterone system in the context of an ACE2 interacting virus. And there is endothelial cell damage, which kind of explains some of the coagulation abnormalities that we see. And there is also a dysregulated immune response, which we are going to discuss. And I like this slide because it doesn't kind of make random things, call it random things like cytokine storm. There is no storm here. It is the cytokine release, perhaps an exaggerated release in some patients. So please don't use the term cytokine storm for COVID-19. Just to kind of get into the one more layer of immunology that is relevant for some of the therapeutics. So the virus enters the cell and it activates quite a number of the intracellular pathways. I just want to kind of bring in two things really. The bottom of the screen, you can see the pro-inflammatory cytokine pathway through the NF-kappa B and the interferon response genes generating type 1 and type 3 interferons. And I think it's got two important consequences. If you get a normal interferon response, you usually have a clearance of the virus. If you get an abnormal interferon response, you're likely to have either impaired viral clearance and or severe disease. And this has got therapeutic value in that you can think about interferon therapy in the context of COVID-19. And there are some phase 2 data that show that inhaled interferon therapy may be of value. And in that context of potential therapeutics, I just want to bring in one lovely study about the inborn errors of type 1 interferons. So this is work from Casanova's group, published in Science, probably coming up to 6-7 months ago. What they did was to screen for abnormalities within the interferon genes in the context of life-threatening COVID-19 infection. And they essentially show that there is an inborn error of TLR3 and interferon 7 dependent gene. TLR3 and interferon 7 dependent gene. And this kind of highlights the value of type 1 interferon therapy in the context of COVID-19. It's been estimated that roughly 3.5% of critical COVID-19 patients may have one or more of these abnormalities that contributes to the abnormal interferon response and abnormally severe disease. Let's come back to cytokines and COVID-19. I'm sure Professor Singer is going to highlight something about the interleukin-6 blockade, which I'm not going to talk about, but I just want to set the scene as the person kind of providing the context for the talk. So this is a lovely work from Dr. Iwasaki's group based in Yale. What they did was to look at patients, roughly 30 odd severe patients, 80 moderately ill patients, and 108 uninfected healthcare workers as controls. And they measured around 71 odd cytokines. And when you think about the cytokine response in COVID-19, this graph essentially summarizes quite a number of things which I want to bring out. So the graph in the bottom triangle is moderate disease, and the graph in the right triangle is severe disease. And in the middle of the graph are the cytokines that are listed, and the negative and the positive scales of the heat map are shown in the bottom. What you see here is that there is an abnormal cytokine response, chemokine, and a number of other proteins in the context of COVID-19. There are differences between moderate and severe disease. And these cytokines and chemokines could be classified into type 1, type 2, and type 3, and based on the type of immune response that they produce. And what you see here is a profound alteration in all sets of cytokines in the context of COVID-19. And these cytokines are things that we understand a lot about, like the interleukin-6, and the cytokines where we have less clear kind of mechanistic understanding of what this might do. But nonetheless, you can see that the complex change in the interferon response, in the cytokine response. There is also a difference between what happens in the severe and moderate disease early on in the disease process. This is patient with a severe disease coming to you within 0 to 7 days of onset of symptoms, or 0 to 10 days of onset of symptoms, is on the top right-hand corner of the graph, and the person who is coming in with moderate disease in the bottom right-hand corner. And what you see here is some systematic differences in the interferon response between early severe and early moderate disease. And this abnormality is even more amplified in the late severe disease, where it is characterized by activation of all three, type 1, type 2, and type 3 cytokine pathways and the responses. So it is plausible, therefore, that just picking one cytokine to treat may not necessarily change the illness outcome. Nonetheless, there are some strong proximate determinants of outcomes, such as IL-6, that may be of value in treating. And in this context, I think we also highlighted some of the abnormalities, and I just want to, I will come back to this paper later on in the talk, but I wanted to just bring in one small point here. A combination of three cytokines, particularly IL-6, IP-10, and IL-10, is both prognostic in that it's associated with bad outcomes. They're also associated with progression towards more severe disease. And some of you who understand the interferon biology will realize that the IP-10 is one of the early interferon sensitive kind of cytokines. And there are, broadly some T cell changes, which I will come on to later on in the talk. And just to contextualize the cytokine in relation to other commonly understood critical illnesses, this is work from Peter Picker's group. And on the y-axis are the concentrations of 3 representative molecules, TNF, IL-6 in the middle, and IL-8 on the right-hand side. And on the x-axis are COVID-19 patients with ARDS, sepsis with ARDS, sepsis with no ARDS, out-of-hospital cardiac arrest, and trauma. What you can see here in particular is the distribution of cytokines in terms of TNF, IL-6, and IL-8. And in fact, if you got sepsis with ARDS, you almost have a higher concentrations of these molecules on average compared to a COVID-19 patients. And that's why I started by saying, please don't call COVID-19 a cytokine storm. This is kind of keeping with the levels that we see in other disease. And I think I just want to bring in one value of this cytokines. One argument that people often make is that you could use cytokine concentrations to target therapy. So I'm not going to discuss therapeutic. I just want to give you the biology background to it. So if you think about interleukin-6 signaling, you have the classic IL-6 signaling, where an IL-6 molecule attaches to an IL-6 receptor on cell surface with the GP130 co-receptor, and then which results in the activation of the JAK, STAT3, and gene transcription pathways. There is also on the right-hand side of your screen, IL-6 trans signaling. The IL-6 trans signaling happens in 2 different ways. One, a circulating IL-6 receptor can get bound to a circulating IL-6, and those 2 things can contact a cell that's got GP130 to have systemic consequences, or a dendritic cell where the IL-6 can then be kept in close proximity to a T cell during the antigen presenting cell to a T cell interaction, where that IL-6 signal could be transmitted. So there are 2 different ways of trans signaling. Therefore, you could block these pathways using either an IL-6 receptor inhibitor or an IL-6 inhibitor. And I think on balance, you can imagine that the IL-6 inhibitor, a receptor inhibitor, might have a greater likelihood of success, given that it'll both affect the classical signaling and trans signaling. And the final point about IL-6 signaling, because I think much of the discussion will be around that, is the classical signaling is not just pro-inflammatory. There are some resolution pathways that are activated through classic signaling. Okay, that's about cytokines. I'm not going to talk anymore about cytokines. I just want to bring in the context of autoimmunity in COVID-19. And probably the first big paper that came out, again, from the Casanova group, published in Science, where they talk about the autoantibodies against type 1 interferons in patients with life-threatening COVID-19. What you see on the left-hand side of your screen is the prevalence of autoantibodies, and that prevalence of autoantibodies is much more common in men, and life-threatening COVID-19 in antibody-positive patients is much more common. And on the right-hand side of the screen, you can see the the table where we talk about the autoantibody prevalence is more in men, and the odds ratio for that is around 5. And the p-value, if it's a small screen, it is not 2.5, it is 2.5 times 10 to the power of -6. And the life-threatening COVID-19 is much more common in the older population, and the prevalence of autoantibody is also common in the older than 65-year-olds. So there is an age and gender specific differences in the biology of the immune response in COVID-19. And that is not unique to COVID-19. It's been described in other conditions, but it becomes an important focus when you start targeting the immune system. And I think in this context, I just want to bring in one more paper, which does a much more agnostic approach, where you can use a method called as rapid extracellular antigen profiling. And this is work again by Dr. Iwasaki's group alongside Aaron Ring and Ale, where they highlight high prevalence of autoantibodies against most of the immunomodulatory proteins, such as cytokines, chemokines, and complement proteins. And the prevalence of autoantibodies is associated with more severe disease. So if you look at the heat map on the left-hand side, on the bottom, you can see asymptomatic, mild, moderate, and severe. And the severe is in red. Now, if you look at the heat map per se, as an example, you have the up regulation of the REAP score is higher in the interferon autoantibodies, as an example. And there are other autoantibodies that you can see with more severe disease. So there is an element of autoimmunity, either it's a triggered autoimmunity or loss of the normal check that you have on the autoimmune responses also in the context of COVID-19. And therefore, you can't ignore the autoimmune pathway and the role of something like steroids in this context. Okay, just for the last kind of say 5-6 minutes on cellular immunology and COVID-19. And there are some fabulous papers out there, and purely for ease of describing and simplicity, I'm just going to focus in on the work that we published. That doesn't mean to say that the others are any less important. They're all important. I'm just going to focus in on so that it becomes a simpler discussion. So what did we do? We studied around 10% of mild, 41% of moderate, and 49% severe COVID-19. And I think amongst our healthy controls, we had two different populations, a SARS-CoV-2 antibody negative, and so SARS-CoV-2 antibody positive, but asymptomatic. So you can see the principal component analysis plot on the right-hand side. The COVID-19 patients separate out, that are in orange, they separate out from the dark and light blue seropositive and seronegative controls. So for the purpose of our analysis, we combine the seropositive and seronegative controls as if they are kind of healthy controls. But the principal component analysis confirms that that is an appropriate thing to do. We also had some sepsis kind of controls in the paper. So just to orient you towards the graphs, which are going to be very similar, on the y-axis are the different cell populations, and on the x-axis are the controls that I just mentioned, seropositive and seronegative in dark and light blue. COVID-19 low, moderate, and severe is in orange, and the lower respiratory tract infection, we have viral and non-viral, and they are in turquoise, light, and dark. And if you got an X on a plot, that represents a patient who died during the course of the disease. So when you look at the innate immune system, what you see is a kind of relatively similar-ish looking neutrophil and eosinophil count. What you start to see really striking is the decrease in the plasmacytoid DCs. Those who are interested in dendritic cells, you can understand the difference between a plasmacytoid DC and the relationship between plasmacytoid DC and the interferons. And a similar sort of changes is noticed in the basophils as well. You get a decrease, acute decrease in the basophil count. So if you look at a snapshot of the innate immune system, you have a relative increase in the neutrophil count, a normalish looking eosinophil count, despite having the Helminth-related cytokines go up, you get a decrease in the plasmacytoid DC and a decrease in basophils. And it is important, therefore, to understand the relationship between the HLA-DR and in COVID-19 and the innate immune system. What you see here is a decrease in HLA-DR expression. And those of you who do sepsis immunology, this is bleedingly obvious. It decreases in sepsis and in most critical illness because there is an increase in IL-6 and there is an inverse relationship between IL-6 and HLA-DR MFI. That is well understood even before I was born. And the last figure on the right-hand side on the innate immune system is an inverse association between IP10 and basophil count, again, signifying the role of the interferon pathway in early viral infections. So now on to the adaptive immune system, in particular B and T cells. I'm going to put up this graph, which is essentially the antibodies. On the y-axis are the peak RBD, IgG, spike IgG, and spike IgM. And on the x-axis are the controls. The seronegative controls are negative. Seropositive controls have got a varying distribution of peak RBD, spike IgM, and spike IgG. And it's important here to highlight that patients with more severe disease tend to have a greater greater antibody concentrations much later on. In other words, early on in the disease, these patients do not generate a defective antibody response to clear the virus that may be contributory. And that is also picked up when you look at the B cell subsets. There is a brisk plasmablast response, and the early plasmablast response is often not a true memory response. So that non-specific early response doesn't necessarily translate into immediate immunity in many of these patients, and patients still have low IgGs against spike and RBD. Now coming on to the T cells, what you see here on the top graphs is the overall T cell count is decreased. There is a decrease in the CD4 T cell count, and perhaps a dose-response relationship between more severe patients have got greater decrease in CD4 count, and the patients who die often have lower CD4 T cell count, and the same applies to CD8 and the gamma delta T cell counts. And this is the reason why you could think about kind of testing drugs that target the T cell therapy. And there is a similar sort of profound changes within the CD8 compartment. Both the central memory, effector memory are decreased in patients with COVID-19. And the final slide about the T cells I want to highlight is the two checkpoint molecules, PD-1 positive and TIM3 positive CD3 T cells have got a decrease, are increased in these patients, and therefore it is a marker of T cell exhaustion, and therefore in effect a decreased T cell function. So if you put all of these T cell changes together, you can see why there is a rationale for something like recombinant IL-7 for treating patients with COVID-19. I forgot to mention in the B cells, if you put all of those B cell things together, you can see why people would go for either a monoclonal antibody or convalescent plasma. So just to kind of integrate all of those T cell changes that I just highlighted, if you look at the CD8 compartment, normal in mild disease, what happens is that you get a clonal expansion of the CD8 T cells, and then you get the effector and the memory T cells. Whereas in the context of severe disease, the T cells are exhausted and the T cell memory is impaired. And the same kind of similar sort of principle could be applied for the CD4 T cells as well. In patients with mild disease, the CD4 T cell does what it says on the tin that it's supposed to do, which essentially forms a germinal center, activates the B cells, develop a longer term memory, and you get antibodies and CD4 positive spike protein positive T cells. Whereas in severe disease, you get an accelerated apoptosis, a plasmablast hyperactivation, and an impaired systemic response resulting in an immunopathology as opposed to beneficial immune effect. So last couple of slides to summarize, I think what I've done is to kind of take you through most of the hospitalized infection patients with COVID-19, a very, very superficial immunology. What you see is both immunoprotective response and immunopathogenic response. The immunoprotective responses are early interferon response, activation of the leukocytes, a brisk plasmablast response, a classic antibody response. An immunopathogenic response is a cytokine excess, an altered interferon response, excess IP10, T cell lymphopenia, and T cell exhaustion. And I'll leave you with that summary slide, and please email or contact me via Twitter if you wanted to discuss this. And I think the questions would be at the end, and I'll stop sharing my slides. Thank you.
Thank you, Professor Manu Shankar-Hari, for this excellent talk, very comprehensive. And we need to progress to the next one. Next presentations is immunomodulators in COVID-19, two sides to every coin. And the speaker is going to be Professor Mervyn. He's very well known for all of you. He's a professor in intensive care medicine, director of the Center of Intensive Care Medicine in the Department of Medicine and Wolfson Institute for Biomedical Research in the University College of London. He's senior investigator in the National Institute of Health Research, and he's editor-in-chief of the Intensive Care Medicine Experiment. He again has an extensive background in sepsis, COVID-19, RDS, and covering basic, translational, and clinical research. And also he's an excellent communicator. So I am very happy to have him on board. So please, Mervyn, proceed with your talk.
Lovely.
And please remind all the attendees that you can make questions through the different platforms, please.
Lovely. Thank you very much indeed, Ricard. Very kind introduction, although slightly, actually, you've got a slightly old bio. Anyway, what I'm going to do is be a bit challenging about COVID, in particular the trials, and perhaps challenging how the trials are being performed and the questions we should be asking. Overall, and I'll show you some data later, the outcomes in many of these clinical trials have been disappointing. However, there have been some really intriguing subset differences that we'll go into. And I think we need to learn from our past mistakes and moving forward, try and improve trial design based on a better knowledge of what we're treating.
There are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns. The ones we don't know, we don't know.
Wise words indeed from actually the recently departed Donald Rumsfeld. And I think exactly the same applies to COVID. As Manu just recently said, and I'll emphasize in my talk, one size doesn't fit all. The subgroups, the phenotypes of COVID do vary. And so perhaps we're trying to shoehorn treatments to everybody when we should be directing them against specific subsets. I've picked on this slide, it's one from Manu's nice paper, and I've just highlighted here T cells, interleukin-6, and he gave you the schema earlier. So if you look at the red bar down the bottom, that indicates low, moderate, and severe illness severity in COVID-19 patients. And if you look here, first of all, at T cells, yes, they're lower than healthy controls, but you'll notice that there is this huge variation even within patients of the same severity degree, going from normal values to very low values. And the same with interleukin-6. Overall, there's an increase, it's statistically significant against healthy controls. However, you'll see there's this huge variation. So even in the most severe cohort, you've got some patients where you can't measure any interleukin-6 and some where it's much more elevated. Of note, the levels, and Manu made the point about please don't use cytokine storm. I'm going to reinforce this point. You'll see the levels go from essentially 0 to 100 and occasionally above 100 picograms per mil. These are not high levels. And so I would argue, rather than a cytokine storm, we have much more of a cytokine gentle breeze in most patients. However, that hasn't stopped this sort of dogma from prevailing, and you see it in paper after paper. Cytokine storm, the anger of inflammation, and these are just some, and here are many more where people go on and on about cytokine storm, and it's very seductive. And so that's triggered a whole load of groups, many of whom, dare I say it, know or have very little previous interest in sepsis, in infection and so forth, to throw a whole load of drugs they have on the shelf at the patient. And these are academic groups, industry groups and so forth. This is a paper we published in November, and these were different targets being used in studies registered in clinicaltrials.gov. And you can see a huge array of different drugs, some against the virus itself, antiviral approaches, a lot against this inflamed cytokine storm host response. As Manu showed from Peter Picker's work, but here's a meta-analysis from Cliff Deutschman's group, again in 2020, so last year, the same message that Manu was talking about. In patients with COVID disease, even severe COVID disease, the levels of interleukin-6 were, in most patients, only marginally raised above normal. They were much higher in patients with ARDS, in sepsis, and even higher in patients with cytokine release syndrome that you see following CAR-T therapy for different cancers. So again, you've got log orders of difference between COVID, the cytokine breeze, and bacterial sepsis, etc., which is much more of a cytokine storm. And it doesn't just apply for interleukin-6. You've got a whole variety of other cytokines that have been reported and are generally much lower than in other inflammatory conditions like bacterial sepsis. But this was known about right at the very beginning. This is one of the very first papers that came out from Wuhan, reported in The Lancet, and they reported loads and loads of different cytokines and other mediators, and I've highlighted interleukin-6. Yes, it was elevated significantly, statistically significant above healthy controls, but that only applied to a relatively small number of patients. There was no difference between those receiving ICU care and those not, and many of the COVID patients had levels at the normal range or only slightly elevated. I've just written this editorial with Andre Khalil about this sort of rush to give these experimental interventions without actually realizing what we're doing from a scientific point of view. And when we wrote this a month or two back, there were nearly 3,000 interventional trials registered on the clinicaltrials.gov website. Only 1 in 7 had been completed. Of those trials, 629, so a fifth, are large phase 3 trials. A third come from industry, 2/3 are academic-led. Only 1 in 8 have been completed. So huge numbers of trials, and unfortunately, the vast majority of them, we haven't yet seen the outputs. And of these trials that have been completed, that have reported, how many have shown a positive outcome? Sadly, very, very few. And even then, there are questions. So why do we have all of these negative trials? It may be the drug or the intervention didn't work at all. There was no effect on the patient. That's scenario A. On the other hand, there may be scenario B, where many were not affected. Some may have benefited, but some may have been harmed. Overall effect, a negative trial. Lastly, you may have scenario C, where many patients aren't benefiting from the drug. A subset is benefiting, but they're diluted out by the no effect group such that there's no statistical significance. So many of these drugs probably did work, or perhaps did work in the right patient, but clearly it's identifying who the right patient is. So we can target those patients who will benefit and avoid giving the drug to those who will be harmed, because clearly that's a bad idea, or those in whom there's not going to be any effect. Because clearly, if there's no effect, we're wasting drug, wasting money, wasting effort, and perhaps giving false hope to patients and their families. So again, we need to understand what we're doing in a much better focused way. And we've learned that over the years with sepsis trials. You know, just giving the drug to everybody, same dose, same duration, perhaps isn't the way we should be treating these patients who do differ. And we were also worried in this editorial that many of these large trials had been commenced using actually quite toxic drugs, anti-cancer drugs, for example, without prior preliminary studies, making sure that these were safe and that there were markers of efficacy. We launched into big trials in the hope that it may work. Is that the right approach? You wouldn't do that in peacetime. Why would you do it necessarily during periods of crisis like COVID? So this concept, oh, cytokine storm, let's block. Why should we aim to block cytokines in all patients, especially, as I showed you, many patients do not have elevated cytokines, and we have an inflammatory response for a reason. It's part and parcel of our protection against an insult like an infection. And then if we are going to block a cytokine, which should we block and how should we block it and for how long? All of these are relevant questions. So from a biological or biological point of view, if you're going to use an IL-6 receptor blocking agent, it's likely to be more effective if there's a high interleukin-6 level. That's a reasonable assumption. However, if the patient has normal or mildly elevated levels, then the argument for using these drugs is much weaker. We'll come to Manu's very nice meta-analysis that came out last week in JAMA on behalf of the World Health Organization. And the overall conclusion was the use of these drugs was associated with lower 28-day all-cause mortality. However, and I always like looking at subsets and supplements because a lot of really interesting data are contained there. So if you look at 28-day mortality, the benefit in terms of statistical significance, so it didn't cross the line of unity, was seen in those receiving oxygen or non-invasive ventilation, no benefit in those receiving invasive ventilation. Gender, or sex I should say now, only worked in male, didn't work in females. There was no significant difference in females. There was a strong signal in males. CRP, as Manu said, we're traditionally brought up to think that IL-6 is a driver of acute phase protein, CRP production. So you would have assumed, if this relationship still held true, that the patients with the highest CRP would be the most responsive to the agent. Indeed, the only significant group was in the intermediate range CRP level. Those with the highest values, again, there was no significant difference. And even though there were a large number of patients within this particular subset. Manu, again, I've had discussions with Manu about this. The statistical argument's different to my simple brain's understanding of it. But you can see there seems to be a synergistic effect with concurrent use of corticosteroids. So when the two are combined together, there seems to be a big effect. But when the patient gets the IL-6 antagonist without getting a corticosteroid, there's a shift in the other direction. So it makes me think, well, actually, does the IL-6 blocker depend on the corticosteroid? So perhaps that's a discussion we can have later. And if that's the case, again, what does the science mean? Do we understand the science? And the answer, unfortunately, is no. Let's just shift over to use another example, but the dexamethasone study, the large one by the recovery trial. You can see here the big signal was seen at 28-day mortality in those invasively ventilated. There was still a positive signal in those getting oxygen, but a sizable number of patients who didn't get any oxygen at the time of randomization, there was no benefit. If anything, the trend was in the opposite direction. Why? We don't know. Looking at the supplement, again, interesting data. If you look at age, there was no effect there was a strong effect in people under the age of 70, but no effect in people over that. Males, just like I showed earlier for tocilizumab, the males benefited, the females didn't benefit at all. In this trial, the strong signal was seen in the Black, Asian, minority ethnic groups. The white populations, where there was a much larger number of patients, there was no statistically significant benefit. There was a strong signal if the drug was started after 7 days from symptom onset, and no benefit if you got there earlier. And in terms of baseline risk of dying, again, the significance was seen in the mild and moderate group rather than the severe group. So lots of questions. Why does interleukin-6 blockade fail according to these data in women, those on mechanical ventilation, those with the low or the high CRP values, but not the intermediate, those not on steroids? Discussion point with Manu later. Why, on the other hand, does dexamethasone fail also in women, white race, those on no oxygen, those above 70, and those who have symptoms within 7 days? How many of these trials actually took the samples to measure IL-6 or other mediators or antibodies or whatever to try and understand these differences? Sadly, it was a big fat zero. And I think that is a very strong learning point. We have all of these differences and we don't understand them. I'll use this. It's a really interesting trial. Well, it's not a trial, it's a study from Spain. So it's, again, it's not a randomized trial, so you have to take this with a relative pinch of salt, but I think it's an interesting hypothesis generator. What they did was they looked at 146 patients where they took blood samples. Some of those patients got tocilizumab, some didn't. And then they followed the patients through for up to 3 months. So let me talk you through it. So the group who had high interleukin-6 levels, who didn't get tocilizumab, had a 36% mortality at around 2.5 months. On the other hand, those with high interleukin-6 levels who got tocilizumab, the mortality was much lower, 16%. On the other hand, patients with low interleukin-6 levels who didn't get tocilizumab had a 10% mortality. However, those with a low interleukin-6 level who got tocilizumab had a 32% mortality. So there was benefit in the group with high IL-6 levels from getting tocilizumab, but it was in the opposite direction in those with low interleukin-6. And as Manu mentioned, you know, interleukin-6 has a whole variety of important properties. It's pro as well as anti-inflammatory. And so maybe, if, you know, taking this on face value, it is relevant that we're helping some people, but perhaps not helping others. The other point I'd like to make is if you look at 28 days, because a large amount of these trials were cut off, censored at 28 days, and that's when the trial stopped. You can see here the patients with high IL-6 who didn't get tocilizumab had a high mortality at that time point, whereas the other 3 groups were very similar. It was only later on that the high IL-6 tocilizumab treated groups showed an increasing mortality signal. So again, we've learned from sepsis trials, 28-day mortality isn't good enough. We can keep people alive or prolong death very effectively with modern intensive care. So we need to look at longer data. So again, going back to Manu's paper, this is the 28-day mortality. There's, again, different discussion point, but there are interesting differences between the studies where there's a blinded placebo-controlled limb and those where it's open label. But if you look right down the bottom, in terms of mortality difference at 28 days, there's a 4% absolute reduction in mortality when you give an IL-6 blocker or receptor antagonist. On the other hand, 90-day mortality, so it's not as complete. The recovery trial, which was the biggest trial by far, didn't report their 90-day outcomes. You can see that the mortalities down the bottom are now equivalent. So maybe it helped early on, stopping people getting off onto ventilators, getting some patients out of hospital quicker, short-term survival. Perhaps the longer-term outcomes aren't as impressive. But again, it's hypothesis generating. The final bit I'll talk about, again, in the title, it should we boost or block the immune response. So if you look at this picture I showed earlier, you've got studies where they're both inhibiting GM-CSF as well as giving an agonist. And unfortunately, we suffer in this COVID world with trial by press release or publication by press release. So GSK, Glaxo, on the 25th of February, put out a press release where they looked at their drug, otilimab, blocking GM-CSF, and they found overall there was no difference. It wasn't statistically significant. This is in 806 patients, but in the 180 who are over 70, there was a signal. It was better in that relatively small subset. And the claim is, the argument is, well, maybe the GM-CSF levels are higher in over 70s, therefore, wouldn't it be a good idea to then just focus on that? So they're now continuing their study, just focusing on people over 70. I would argue, why didn't they measure GM-CSF and then treat those patients with high levels? A day later, Partner Therapeutics put out their press release where they're giving GM-CSF, and this is by inhalation, and this was done in Spain, I think in Belgium rather, in 5 hospitals, 81 patients, and there was an improvement in oxygenation, clearly not powered for outcomes, but again, there was a signal towards benefit. And there was this nice review, well, how can you reconcile giving opposing therapeutic approaches of the same treatment in COVID-19? And they make the point that, yes, GM-CSF is important to perhaps improve lung function, strengthening the alveolar wall, enhancing viral clearance, whereas blocking GM-CSF or the receptor may help this non-existent cytokine storm. But they make the point, which I think is really valid, care should be taken with respect to dosing, route, and timing of administration for each therapeutic approach. We need companion diagnostics. Finally, I'll mention this trial. It's, again, publication just on the MedRxiv, but the recovery trial's latest studies on Regeneron's monoclonal antibody combination. And this was a big trial looking at 2 monoclonal antibodies, and I can't even pronounce them, casirivimab and imdevimab, which bind to 2 sites on the spike protein of the coronavirus. And hey presto, if you look at all participants, nearly 5,000 patients in each limb, so a big study, there was no overall effect. However, in this trial, they did take blood samples and they could look retrospectively at those who did or didn't have endogenous antibodies. And in the third of patients who didn't have endogenous antibodies, there was a positive signal. So there was a benefit in that cohort and no benefit in the other. And again, here's the odds ratio plots, big benefit in seronegative, no benefit in seropositive, discharge alive from hospital, invasive mechanical ventilation, or death, a composite outcome. So interesting. So that, to my mind, is the way forward. Let's find something to measure, find the right patient, and then treat accordingly. So in summary, COVID-19 doesn't trigger a single pathological response, even in patients of equal illness severity. And we have these highly heterogeneous subset responses to different therapeutic strategies. Some benefit, but not others, and some are even harmed. And so we currently lack the science to understand why and how, and I think we really, really need to change this. Thank you very much indeed for listening. I'll hand you back.
Thank you very much to both of you. I think we have seen the research of 40 years of sepsis in just 18 months, but with some of the previous mistakes we make in the last 40 years, especially without enrichment in many trials using biomarkers or phenotypation or whatever. So I think we did a lot of work. But again, probably in the design of the trials, we have some improvements to make based on the lessons learned in sepsis. We have some questions from the audience. The first one I want to make is about the role of the different variants. Do you think different variants play a role in the pathophysiology, in the response to therapies and the prognosis? Any of you, or maybe Manu?
Thanks, Ricardo. I think it's not my area of expertise. All I would say is as the viruses mutate, they mutate for a reason, either increased transmissibility, which is the most common reason for evolution. So the biological kind of differences that you see may be partly driven by the host response as opposed to the viral mutation, but I'm not an expert.
Yeah, there was some studies in the UK when we had the Kent variant, if you remember, before we had I can't remember, was it the Alpha variant now, I think it's called, and there were some studies at my institution where there were some immunological differences between the previous variant and the standard one and the Kent variant, and certainly again I noticed, whether or not it's relevant, that we certainly in the first wave saw many more patients coming in with thromboembolism presenting de novo, which we didn't see in the second surge. Now, whether it's because patients waited later, whatever, I don't know, but there did seem to be differences in the patients. And certainly in the second surge, it seemed like patients were stuck on ventilators for longer. Again, it's purely anecdotal. I've got no strong scientific evidence to base that, but I do wonder whether the variants do trigger a different host response, or, you know, in some ways. I don't know if Manu or you Ricardo, want to comment or have thoughts.
No, also I have no experience on that. We have experienced the transmissibility that increases with the alpha and then now with the delta, but not about different in some biomarkers of inflammation, etc.
Yeah.
Another concern is about adverse events, especially superinfection. And what can you say about that? Do you think there is additional risk of superinfection, especially with tocilizumab or dexamethasone?
Manu's done that. Go on.
No, I think I'll come back to it. So the 28-day secondary infection rate in patients who got tocilizumab or sarilumab or ciltuximab versus usual care was not different. Even when you stratify it by receipt of corticosteroids, the odds ratio is 0.96 and the confidence interval straddles 1. So there is no difference in the 28-day secondary infection risk. And if you think about the bias that Mervyn highlighted with open label trials, I think you can see that open label trials with sarilumab report a greater infection in those who got sarilumab. But actually overall, when you look at it, it doesn't make a difference. So I don't think based on our data, I can say that it increases the risk of secondary infections. If anything, it does not, is what I would conclude.
Yeah. Just again, as a comment, that again, it's association rather than cause and effect. But certainly in the second surge in the UK, we were seeing a lot more bacteremia than we were used to, and we were getting, you know, a lot of like gram negatives, and we even got, I think in our unit, 4 Staph aureus bacteremia. So it could be dirty hands and poor infection control, but on the other hand, you know, whether it's steroids, because obviously there was a lot more steroid use, don't know. You know, and hopefully, you know, we're trying to look back at our data now to look at this point, but maybe not. It might just be epiphenomenon rather than cause and effect. But, you know, theoretically, there is a risk.
There is no risk. You don't want to get the wrong message across. So I think to me,
no, theoretically, you can't say there is no risk, because theoretically, you know.
True, absolutely. Theoretically, there is a risk, but based on the RCT data, of 28-day secondary infection rate, there is no difference between IL-6 antagonists with or without corticosteroids.
Okay, we have 1 minute for one additional question that is related to the role of age. So we have different impact in terms of severity according the age, and also different response to therapies according the age. No, you mentioned otilimab, which seems to work above 70 years. And on the other side, you mentioned steroids that it seems to work better below 70 years. So why age has an important, it's because immunosenescence, or why age is playing such an important role in this condition?
Go, Manu.
Okay, so I'll start and then Mervyn can come in. So you're absolutely right, Ricardo. There is a reversible element with immunosenescence that contributes to the increased risk. As you get older, there is also quite a lot of irreversible risk with comorbidities and age per se. So there will be always an increase in outcome risk with age. It's a good prognosticator. Biologically, immunosenescence and decreased reserve would be the other reasons.
Yeah, I'd agree. Yeah, no, absolutely. And there are, again, some suggestions. Again, I mentioned that maybe the GM-CSF levels increased with age, for example. So again, it's how the immune response, because we know it does change with age anyway, you know, but then how that aged person, and as Manu mentioned, obviously they're much more likely to have comorbidities and being treated for those comorbidities, you know, how that impacts. So I think, again, it's a really, really important question. And we know, you know, certainly, again, UK figures, I think 3/4 of the deaths, if not more, occur in patients over the age of 75. So, you know, clearly this is a bad target population in terms of poor outcomes.
Okay, thank you very much to both of you. Excellent talks, excellent discussion. Thank you for all the people that attend this meeting and also for your active participation with questions. And of course, thank you to ESICM and all the technical support. Bye-bye. Have a nice afternoon.
Thank you so much.
Bye-bye.
Bye-bye.